but just still.
I think all of you
Lovely.
die.
Yes.
But 6 and 7 are still.
You're the only one who saw it.
No, out of 50 questions, if you get 6 to 7 of them wrong, you're still passing.
Still an 82.
Okay? I promise you're going to do fine.
What about for the final?
What about it?
Statistics.
I only have about 33 questions.
Oh, and
Peds is only 33
you said we
questions.
make up like some of the questions, right?
For your second exam. Yes. So on the second exam, it is also 50 questions, but 10 of them are questions that you create and post into Canvas. So you have the question and answers word for word exactly like they will be on the test.
10 questions. What
It is
is
10
our
questions.
professor's name?
Doug. Kevin. Oh, I'm getting a cat and I'm naming it Kevin.
Oh, Kevin.
7.
Perfect. And how does for Halloween?
No.
Oh.
No.
Dress him up like the bird. Kevin.
Okay, let's go through this case study really quick, and then I have an escape room for you.
Yeah, no.
All right, and the escape room, the faster you get it done, the faster you can leave.
I thought you had to give us extra.
There's no extra credit in nursing.
You never know.
You crazy.
Extra credit nursing. No.
You want like 6, 7 extra credit points? Okay. All right, for this, our story begins. Maria, she is pregnant with her third child, Joseph. She has adequate prenatal care, regular checkups, and no complications to date. At a 19-week prenatal scan of Joseph, they found severe congenital heart problems, including pulmonary stenosis, overriding aorta, thickening of the right ventricle, and ventricular septal defects. Tetralogy of Fallot. Tetralogy of Fallot, right? There's 4 defects, right? Okay? Good. He was born and admitted to the pediatric cardiovascular intensive care unit at birth due to severe central cyanosis and respiratory distress. He was noted to have an oxygen saturation of 70% at the time and was resuscitated and given 5 micrograms per kilo per minute of prostaglandin E1. On appearance, he was dusky looking and his peripheries were cold and cyanosed.
To avoid the closure of
To avoid the closure of the PDA, right? We want to keep that PDA open. Absolutely. Good. Okay. So he went in for a cardiac cath and confirmed the antenatal findings and diagnosis of tetralogy of Fallot. Okay. He was started on continuous positive airway pressure, or CPAP, to maintain a positive end expiratory pressure, or PEEP. His CPAP was delivered using nasal cannula the following day after his SpO2 increased to 80%.
Yeah, that's cool.
For tetralogy of Fallot, this is good, right? We know that their rate is going to be a little bit lower. 80% is great, okay? So he remained on CPAP for the first 5 days after birth, which he subsequently was weaned off of when he was able to maintain his oxygen saturation greater than 80% on his own. Total parenteral nutrition was initiated through a central venous catheter. Why would we do that? Desetting when he feeds, right? He was probably becoming very cyanotic, very fatigued. It wasn't ideal for him to be orally feeding, so we're gonna give it to him through a central line.
Why,
Okay.
why would you do that versus
Give his body a rest to
Yeah,
digest.
because if giving it through the NG, you're causing the GI system to utilize oxygen. Yeah. So having to digest all of that instead of just being right through the vessels, he's using oxygen that way. So whether he was taking it by mouth or he would still be activating the GI system, so they're going to do it that way. It's not going to be long term, and ideally they should still be giving him a pacifier so that he's got something in his mouth using, so that he's not going to get oral aversion. Right? So we still want them, even though they're getting fed this way or getting their nutrition that way, we still want them to try to put the pacifier in and at least like,
Even with their bowels, you don't want it to get.
right, like you don't want to cause an ileus, right? So at least that, like he's swallowing some like spit and stuff like that while he's sucking on that. So we're still promoting that kind of like sense of feeding while he's getting fed, but not actually having to do it himself. So he was given, getting that, and then he was given 6 mLs of express breast milk every 2 hours via a bottle, and he tolerated his feeds very well. So we'll start with a very low amount, so that his body isn't having to process a whole lot at first, right? Because 6 mLs, does that seem like a whole lot? It's not a whole lot,
Also,
right?
their stomachs are like this big.
They are, right, initially, but they should be able to tolerate somewhere between like a 15 to 30 ml feeding initially, right? So we're even cutting it back from that. Then they were able to increase the feedings to 30 mLs every 3 hours, and his TPN was discontinued. He is passing urine normally, and his stools are of normal consistency. Joseph weighs 3.5 kilos. Is this intake volume appropriate? Does it seem appropriate? So he's only a couple days old. 30 mLs every 3 hours. Does that seem like a decent amount?
Yeah.
Yeah, absolutely. Right? It doesn't say in there anything about increasing calories. They could have been doing that too. So maybe they were doing a smaller amount with an increase in calories. That is an option, right? His urine output is approximately 12 mLs every 3 hours. Is this output volume appropriate?
I thought it's supposed to be equal to the feed. Is it?
We did the calculation in clinical. Do you remember how to calculate?
See, that was the thing that we didn't understand.
What didn't you understand?
We had so many questions about that whole thing.
Well, we all.
Oh my gosh, really?
Everybody had a
Okay.
different amount.
Yeah, we had so many questions about
Okay.
it, and it's never really went over.
Okay.
Well, everybody had a different amount.
Will that be on the test?
It's like,
You said no. When I asked it clinical.
I can't remember.
like when we asked about it, our instructor was like, yeah, I don't know.
Cool.
Like legit, she was at the table
Lisa!
trying to figure it out with us. She's like, yeah, I don't know.
Lisa!
These are some great questions. I don't have those answers though.
Thank you so much for asking about it.
It just further reaffirmed my decision to not be a pizza seller.
It's really not that hard.
Wasn't
Okay.
it like a range?
Okay.
Think about
Okay. So here is your calculation, right? So the 4 kids that you had at that station weighed 4, 6, 10, and 12 kilograms.
Yeah.
For your 4 and 6 kilogram kids, they should have 2 mLs per kilo per hour out of urine. For your older kids, like the 10 and 12, they should be between 0.5 to 1 mLs per kilo per hour of urine output, right? So the example that I had fell in between here because I wasn't going to give you the math for the one that you were supposed to calculate. So you've got a 5 kilogram kid, their urine output should be 2 mLs per kilo per hour. So you've got 10 mLs per hour, right? Over your 12-hour shift, they should have 120 mLs out over your 12-hour shift. Okay? So he was 3.5 kilos, and he had 12 mLs every 3 hours.
Oh yeah, no, he's way under. He should be way
Okay.
Well,
So
That's 3 seconds.
So 12 times 4 is what?
why are we doing 12 times?
That's 48.
Because every 3 hours.
48.
So if he's doing 12 every 3 hours over a 12-hour shift, right, is you're calculating the time, your 3 times 4 gives you the 12 hours, right?
Okay, so 48.
Questions on this?
What?
Yeah, we need some. But I thought
Are there some
Karen said that,
posted in there?
OB
If not,
should be-
registered nurse RN, Nurse Sarah has some.
Didn't she say?
Okay. Yes.
And one is, so for the question, is this output volume appropriate? Do we go based just off our calculation? Or do
Yeah.
we consider
So-
input at all?
No, so I'm just asking you if the output is appropriate.
So based off calculation?
Just off your that calculation that I just showed you. Yeah,
Okay, so
okay.
Cause when
So
we
that calculation
did,
would
we
be
had like
2.5.
all this input and barely any output,
It
so
should
we
be
were
like,
like,
Karen said it had to be it could be too long for
He's
one
nine
day.
Okay. What?
no, when we did
Oh,
the
no,
calculation
this
around
was everything.
clinical, we had like a bunch of
Because
input,
practically
Yeah.
but
everything
not a lot
Aaron
of,
told me was,
output, so
stop
we
trying
were
to be a
wondering
medic.
if that was normal or.
Start thinking like a nurse. Well,
So,
how do I do that?
so what I had you do in that station, yes, some of them had a lot of input and some of them had not so much, but their urine didn't match their intake, right? So one kid was significant, or 2 of them were significantly dehydrated, and the other 2 had adequate urine output, right? Now that's just like a snapshot of data that you're pulling from your eyes and nose, right? So the other things that you have to take into account when looking at that is your patient condition, right? Their weight. Are they, is their weight increasing? Like if they're retaining all of that fluid, right? Or are they starting to get like crackles? Are they fluid overloaded, right? So there's a number of things that you have to look at to determine like what's going on with your patient, right? So this is just a snapshot of what's happening, right? Okay. So your patients.
So based on that calculation, his output should be 84. So 3.5 times 2
For the 24
times
hour
12
period,
for the
yeah.
12-hour period.
Yes.
Should
So
be 84 milliliters.
and he's putting out how much?
He's putting out 48.
He's putting out 48, right? So he's only about
Should be 84 based
Should
on
be
that
84.
calculation.
yeah. So if you do that calculation, right? So if you had 3.5 times 2 is going to give you what? 7, right? Times your 12 hours
84.
gives you 84, right? But if you do the calculation for his urine outputs, so he's doing 12 mLs every 3 hours, right?
12 times 4 is 48.
So he's really, no, he's way over. It's not 48.
What?
Well, 12 times 4.
So you're doing, it's 12 every 3. So if you do 12 divided by 3, you get the hourly rate, right?
Yeah.
So it's 4, and then times 12. So you do get the 48, right? Is that math right?
Can you write it down?
Still under.
Yes. Okay.
Yeah, he's still under.
So he's way, yeah, so he's way under. So his output is not adequate. So you've got, what?
Keep going, keep going, keep going.
What?
Okay, so your kid is 3.5 kilos, right? And we are going to multiply that by his,
Two.
Times 2.
yes, just so you can see where I'm getting all of the numbers.
Based on the calculation.
Right, so 2 mLs per kilo per hour, right? Okay, so your 3.5 times 2 gives you 7 mLs per hour, right? Per hour, okay? Times your 12-hour shift, okay? And this is where we got 84, yeah? Okay. In a 12-hour shift. Okay? So, this is what he should be putting out, but he is really only putting out 12 every 3 hours. So this is what we want per hour, right? So we're doing 12 divided by that 3 gives us 4. So he's really 3 mLs per hour under what he should be, right? Okay, and if you multiply that by your 12-hour shift, you get 48, right?
Yeah.
So in Peds, we're not worried about the intake, we're just worried about the equations? The formula?
You're looking at both. So you want to know intake and output, right? So you're going to look at the overall fluid balance. Okay. So he's not, at this point, he's not putting out enough, right?
He's fluid positive anyway with the ML drinking.
Yes. Right. So he's taking in 30 every 3 hours, but he's only putting out 12 every 3 hours. That is not a good fluid balance. It should be much closer. Okay. So his output is not appropriate. His intake is good, but his output is not. It's low. Okay?
Wait, Professor Bullet. The ranges where you're doing the 2 ml versus the 0.5, is it always gonna be 4 to 6 and then 10 to 12, or what are the ranges that we need to know for when we have to do that on the test? Like, not.
I will tell you what you're gonna get.
Oh, okay.
Yeah. I will tell you that their expected urine output is either 2 or 0.5.
Okay.
Okay. That will be very clear. Okay. All right. A typical comment made by parents that would alert the nurse about a presence of a congenital heart defect is what? B.
I agree.
He tires during feeding. Because is a growing kid always hungry? Yes. Are they fussy for several hours a day? Do they sleep all the time? Yes. Those are no. All right, so then, gathering that family history, right? We talked many times about how gathering family history is really important to make sure that we're narrowing in on our pediatric diagnoses, right? So, Joseph's father was diagnosed with cardiac defects. He has an atrial septal defect, pulmonary stenosis, and right ventricular dysfunction. Joseph's mother has asthma and during pregnancy was diagnosed with gestational diabetes. During pregnancy, she was prescribed inhalers, betamethasone and albuterol. His mother is a non-smoker and does not drink alcohol. Baby Joseph is the 3rd child in the family. He has 1 brother and 1 sister, and his brother was also diagnosed with a cardiac anomaly, tetralogy of Fallot. So based off of that data, what can you gather?
His parents just stopped having kids.
Besides that.
Family history,
Yeah.
male.
Family history.
Family history along the male line, right? Sister is fine, mom's fine, she just had gestational diabetes, which it doesn't say that she has anything cardiac-wise, but his brother also has a cardiac abnormality. So it would signify that it is a familial along the family line, the male line, right? Okay, so you arrive on the unit for your scheduled day of work. You receive a report at the bedside, right? Because that's where we give and get reports. Of course, every single time. That's where we give and get reports. After receiving a report, you go in and you perform your assessment. These are your vital signs. Is there anything abnormal?
This is for baby.
There are some things that are abnormal, but are they abnormal for the defect he has? They are expected for what he has, right? So that low oxygen, all of that stuff is all normal for the defect he has, right? Why would you see a higher heart rate and a higher respiratory rate?
Because it's not oxygenating and it's trying to pump.
So they're trying to compensate, right? So you're gonna see that those things are elevated a little bit. Good. Okay, here's your physical assessments. Is there anything abnormal?
Abnormal to him or?
abnormal?
Was
Five,
six.
So what this is saying is that there's no radial delay, meaning if you're assessing both pulses, you're getting all the beats on both sides at the same time, right? And whereas if there was a delay, you'd feel one and then the other. You're not feeling them at the same time. Okay. And same thing with the radial femoral delay. So if you're palpating the radial pulse and the femoral pulse at the same time, you should feel the beat at the same time. Okay, so he has no delay there. Cap refill looks good. He's got a warm core, cool hands and feet. Is that expected, normal? Kind of. It's expected for what he's got going on, right? Okay. Lungs clear to auscultation, so there's no fluid in the lungs, no abnormal sounds. Mild hepatomegaly, not a super big concerning issue there. He's uncircumcised, his testes have descended, Tanner stage 1. He's not in any distress or pain. Everything else looks good. Yeah?
Yeah.
Good. He was also slightly blue to the tip of the tongue. Normal? For what he's got going on.
Oh, for
Yes, for what he's got going on.
83% on room air, yeah.
Yep, for what he's got going on.
Oh.
Thank
You made
you.
that kid. That one's good.
Huh?
No.
What's that look
You
like?
made that?
No, that's a baby.
That is
know, I think I know that baby.
non-AI generated.
Who's that baby?
My friend Savannah went to school here, her son, his name's Winston, I'm pretty sure that's him.
I did not steal the picture from any students.
It was given freely.
If it is, that would be incredibly crazy.
In exchange for grades.
Because I actually didn't put the presentation together. This is adapted from another instructor from another institution.
Oh, really?
Yeah.
That's really
It's like,
I'm not kidding, it would be weird if it wasn't him.
That actually, I think it might be this picture. I think this is actually Jimmy Kimmel's baby.
Okay, maybe not, but it looks just.
Because Jimmy Kimmel has a son with tetralogy. So, based on your assessment data, what is your priority care intervention? But do you?
Yeah.
All findings are normal for tetralogy flow,
Yeah.
right? We don't want to throw oxygen on them if they're not having a TED spell, right? We want their oxygen level to be a little bit lower. Like I said, it is crazy how it works, but it actually decreases the cardiac workload if the oxygen is a little bit lower.
Would applying oxygen almost work like people with COPD?
Kind of.
Kills their respiratory drive?
Yes. Yep. Same kind of concept, right? Just like with your individuals with COPD, you don't want to just throw oxygen on them because it could kill their respiratory drive, right? So similar concepts. Everything is normal. We're not going to do anything. We're just going to monitor. What form of treatment do you anticipate?
Yep, I did. Yeah, is this SATA or is this
No, it's multiple choice.
50 seems like a lot.
It does seem like a lot. It's not the right answer.
Oh, let's go.
B is your correct answer, right? So he's got tetralogy of Fallot going on. He's got all of those defects, right? We are going to anticipate surgical options to repair or temporary repair using a shunt, right? We need to fix that circulation, right? So that is our that's going to be our go-to. Because Dig in tetralogy of Fallot, is there a problem with the pump itself? No, right? So we wouldn't give dig, right? 15 mLs an hour for a newborn for a fluid is a lot, right? That is too high of a rate. And so your only viable option there is really B, right? That surgical option. Okay? So what do you know about tetralogy flow? So these are some more statistics about it. 75% of all cyanotic defects are tetralogy of Fallot. Right? It causes decreased pulmonary blood flow. On an X-ray, it has a boot-shaped appearance. So it has kind of shifted from like this kind of downward shape here to kind of this one. So you're seeing this is the outline of the heart. Right? So it has shifted to that kind of boot shape within the chest cavity there. Okay? Those hypercyanotic TET spells, we're going to do knees to the chest, we're going to do morphine, we're going to do oxygen. Okay? The doctor comes to the patient's bedside to speak with the mother and tells her since her baby has several cardiac defects, surgery is needed. He discusses the surgery with the mother, and she says she has no questions for the doctor. See where this is headed?
Yeah.
Once the doctor leaves, Joseph's mother asks, "What is tetralogy of Fallot?" What's your best response to her?
Let me go get the doctor.
Well, it's not now.
You need to ask the doctor.
It's not about the procedure.
Because it's not about the procedure itself, it's about the diagnosis. So can you tell mom what tetralogy of Fallot is? Absolutely.
So
Absolutely. It's a complex heart condition that involves several congenital heart defects, right? Your conversation isn't going to stop there. You're going to go into what that means, right, and go over all of that. Okay? So you receive orders that Joseph is scheduled for surgery to have a palliative shunt placed at 5 p.m. today. You review the orders and begin implementing them. Consents from the parents are obtained after they verbalize they have had no other questions, right? We can only do those consents if they have no further questions. Okay, so you're preparing the baby for surgery. What would you expect to find?
Yeah, we want to go.
All of the above. Why do we want the ECG?
Because you want
their
before and
baseline.
after.
Because we want a baseline. We want that before and after, because after surgery, we're going to do another one.
You're working
Right.
really hard.
We want nothing by mouth. Why?
Saturation.
Right. They're going into surgery. We don't want that aspiration risk there. And preoperative antibiotics. We're going into the heart. Think we want to give them a little bit of extra protection? Absolutely. Right. So, how do you prepare the parents for Joseph's surgery?
So now he's gonna look after he come out and how he might, this how he would look and how you gotta take care of him, or what you doing to take care of him after.
Okay. What types of tubes? What types of incisions? Absolutely. You're gonna tell them. Wow. Next slide. That's poorly timed. Oh my goodness. Okay. So this is the surgery they do, right? So they'll do a Gore-Tex shunt between the branch of the aorta and the pulmonary artery over here. And then they do a pulmonary artery and right ventricular patch here. And then they remove the muscular obstruction here. They close the VSD with a patch, and then the repair is complete, right? So there's a lot that goes on there. So you're gonna tell him that he looks like this when he comes back, right? Is that gonna freak a parent out?
Yes.
If
Yeah.
you didn't talk to them beforehand?
Yeah.
Absolutely, right? So, what are your post-operative interventions and assessments for him?
Baseline vitals, ECG, those are tubes.
Okay. Infection prevention, monitor those tubes and drains.
I'll make sure he get nutrition.
Okay. His nutrition, his hydration status, pain management. Okay.
Is that to
Good.
keep him from like touching it?
Yes. Yeah.
Little baby Joe
Is-
monkey bars?
Yes. Yeah. Little baby no-nos. Yep. They keep the hands there so they're not going to play with everything. Yep.
That's
Okay. So recovery-wise, he does well. He slowly increases the amount he's able to bottle. His current weight improves to 4.3 kilos. His goal intake to go home is 50 mLs every 3 hours. It's now time for discharge. So he continues to recover well, is now bottling most of his goal volume. The doctor writes discharge orders. What type of discharge education might you anticipate? Okay. His activity level? Okay, 6 weeks. Follow-up visits.
What to
Who,
look for.
what, where, when, right? Is he gonna follow up? Okay. What did you say?
Things to look for that might be complications to bring to the doctor.
Absolutely.
Adverse effects or whatever.
No excessive activity, right? On that discharge paperwork, it breaks it down into 2 categories: when to call the doctor, when to come back to the ER, right? So which things are gonna bring you where, right? Signs of infection, so fever, right? Redness, oozing, drainage around those incision sites. Okay. All of that stuff is going to be in the discharge education. What?
They do some of the surgeries in like steps as
Yeah.
they get older sometimes.
They should all happen between that like 3 and 12 month period, but they might not all happen in one surgery. So they might go in and do like that shunt first and just kind of make it a palliative thing and make sure that that has, that there's no complications there before they go in and do the other pieces. Because if they do too much, they run the risk of
Not knowing which thing is not working and.
correct, or if like one fails or they all fail, right? So they just kind of want to go in and do, it will be a multi-site surgery. Okay. What impact will this condition have on the rest of his life? Right? He's going to be followed by cardiac, right, or cardiology. But overall, should he grow and develop normally after repair? Yeah. There's no reason why this should restrict him for the rest of his life, right? Other than continuous monitoring of his cardiac system, right?
Probably should be like scaling.
So, what anticipatory guidance can you give the parents about Joseph as he grows now that he's had his surgery? So we kind of just talked about that, right? He's going to grow and develop normally, right? So just like with any child of his age, you're going to make sure going over like those safety topics, right? Maybe a little bit more as far as like if he's playing like contact sports, you know, should he playing contact sports? You know, if he takes a blow to the chest or anything like that, could that have an effect on him, right? Okay. I don't think that's the same baby.
I'm pretty sure it's not.
Cool. Feel pretty good with tetralogy for Philip? Good. Okay. We're still not done. So don't go anywhere.
Get my hopes up.
Oh, is that not the paper?
What?